Good afternoon. We'll start our program shortly, but before that, I want to thank you for joining us at City Club of Eugene. Welcome to City Club of Eugene's July 19th program, The State of Healthcare in Oregon, Part 2. My name is Joel Curran. I'm past president of City Club and chair of the program committee. We're coming to you from our home in the Fifth Street Market in the heart of downtown Eugene, and it's my pleasure to extend a warm welcome to our speakers and to all of you joining us in person, online, or over the radio. For 3 decades, City Club of Eugene has remained dedicated to the founding mission to build community vision through open inquiry. In accordance with our mission and purpose, we hope to help connect people throughout the community and across generations, identities, experiences, and perspectives. You are invited this week and every week to join us and share your wisdom, learn something new, and take active steps to make a difference in the city and the region we love. Of course, we can't do this alone. A special thank you to our Platinum Community and Diamond sponsors, Eugene Area Chamber of Commerce, serving as a catalytic leader in creating a vibrant and diverse economy that drives economic opportunity and well-being. Kaiser Permanente exists to provide high-quality, affordable health care services and to improve the health of our members and the communities we serve. More information at kp.org. The University of Oregon has helped Oregonians question critically, think logically, reason effectively, communicate clearly, and act creatively and live ethically since 1876. Get more information at uoregon.edu. That's the first time I ever read that correctly. Lane Community College transforms lives through learning. LCC provides comprehensive, accessible, high-quality educational opportunities that promote student success. For more information, visit lcc.edu, and thank you to the City of Eugene and Lane County to support as well. Whether you are joining us for the first time or you're a long-time listener, I invite you to support our work by becoming an individual member, a business or community sponsor, or volunteering to be part of a committee. I can get you on the program committee. So call me. You can do all of these things and more at cityclubofeugene.org. We have a great panel for part 2 of our discussion about the state of healthcare, which will be moderated by Dr. Nicholas Jones. Dr. Jones is a family medicine physician who completed medical school and residency training in Texas. With a desire for patient-centered care and a love of the outdoors, he joined Oregon Medical Group in 2020 because it was an independent physician-owned and surrounded by nature. Frustrated by the corporate practice of medicine, he now works to expand physician control over medicine through national, state, and county medical associations, and in his new clinic, Clear Health Direct Primary Care. Dr. Jones, thank you for modeling, and he will introduce the other speakers.
Thank you, Joel. Let me raise that up a bit. And thank you, City Club Eugene, for hosting this critical conversation on healthcare. Like most physicians, I went into medicine because of my affinity for science, curiosity, and a desire to help others. The average physician spends over a decade and $250,000 learning the art and science of medicine. For 5 to 7 of those years, we dedicate nearly every waking moment serving underserved populations and learning as we do so. In school, we are told that there is such a desperate need for physicians that we can find a job of every specialty in any community we wish to serve. What they didn't tell us is that the vast majority of those jobs are working for insurance companies, huge hospital systems, or private equity, all trying to extract profits from healthcare. There is a growing trend of vertical integration where insurance companies seek to control every step and transaction of the healthcare system, and doctors are seen as cogs in that highly profitable machine. Physicians are no stranger to sacrificing their time, but when you get home 2 hours late every day, spending hours on your days off trying to catch up, something has to give. Sprinkle in a young family and the fact that as much as 40% of our time is spent on unnecessary, unpaid administrative work, and you have a recipe for moral injury. These once passionate docs cutting you off at one or two medical concerns make less eye contact and seem increasingly distant. I believe more physician autonomy, leadership, and control over healthcare, and to reduce the corporate stronghold on physicians and the healthcare system. To discuss how we can make meaningful progress, we have Hayden Rookley, healthcare law and policy expert, Eugene's own Rep. Nancy Nathanson, and House Majority Leader Rep. Ben Bowman. Please join me in welcoming them.
Thanks, Nick, and thanks everyone for being here. I'm Hayden Rookley, lawyer here in town, and I want to talk a little bit before we hear from local elected representatives. I hope this is high enough. Want to maybe frame our discussion a little bit around sort of broader trends in the healthcare system that we've seen here in Eugene, statewide, and also nationally. And I think a good sort of place to start is to sort of take stock of trend over the last 2 or 3 decades of growing corporate consolidation or corporatization in our healthcare system. And I think we all sort of intuitively experience this in different ways, whether we're clinicians or patients or in the community. But I think it's best thought of as sort of a transfer really of power and influence away from physicians and clinicians and their patients and their communities, and increasingly into the hands of large corporate entities and financial investors and insurance companies in our healthcare system. And there's a million ways to sort of quantify the way this has happened over the last 2 or 3 decades. But I think one way to sort of measure this transformation is just to look at the changing dynamics, and Nick talked about this a little bit, of physician employment. So physicians today, in a sea change from decades prior, nearly 80% of physicians today are employed by some form of corporate entity. This might be a large hospital system here in Eugene, a large regional Northwest nonprofit hospital system, or for-profit national hospital chain here in Eugene, in Springfield, or, for example, private equity investment has skyrocketed in the last decade. Retailers have increasingly gotten in the business of providing national retailers like Amazon and Walmart. And then also, and Nick alluded to this, we're seeing insurance companies, particularly in the last couple of years, really aggressively get into the business of providing medical care for a host of sort of both healthcare policy financing changes that we've seen, as well as changes, legal developments, particularly in antitrust law. We've seen a real rapid transformation, a restructuring of our largest insurance companies to become vertically integrated, as Nick mentioned, where they're not just insurers, but they're also owning numerous aspects of the care delivery system and actually the pharmaceutical supply chain. So pharmacy benefit managers and pharmacies, as well as primary care offices, post-acute care providers, urgent care providers, behavioral health as well. So we're seeing this trend really pick up, this kind of new frontier of consolidation. And I think it's certainly pertinent to what we're experiencing here in Eugene, as we've seen United, which is an insurance company which is now the largest employer of physicians nationally, acquiring Oregon Medical Group. So just a couple words on maybe what this means. Why is this happening, and what does this mean for our healthcare system? There's an optimistic case for this, that insurance companies getting into the business of care provision might drive efficiencies in our healthcare system. That if we have insurance companies which are incentivized to keep costs down, if they own physician practices, if they own pharmacies, they might better coordinate care, they might be able to drive efficiencies in the system and essentially manage the patient in a way that reduces costs, keeps them healthier. The problem is here, there's very little evidence of vertical consolidation driving better outcomes in the healthcare system. We've seen forms of this both through hospitals becoming insurance companies over the decades, as well as hospitals getting in the business of owning physician practices. And there's little evidence to show the theoretical benefits of these sort of efficiencies of these large-scale integrated entities. And I think more to the point here, and something that I and colleagues have been writing and talking about recently in the last couple months, is there are particular concerns we might have about insurance companies getting in the business of owning aspects of the care delivery system. And I'll just highlight a few, happy to elaborate in Q&A if there's interest. One is there are all sorts of financial games that we might be concerned about insurance companies playing when they own physician practices. For example, it's no coincidence that the largest insurance companies here are ones that are very prominent, the biggest insurers in our public programs, and particularly in Medicare. So you all might be aware that Medicare is increasingly privatized. The majority of Medicare beneficiaries actually get their benefits from a private insurance company, United actually being the biggest one. And when they own physician practices, and Nick can certainly speak to this and other clinicians as well, there are all sorts of games they can play to increase the amount of money that they get from the government to administer the Medicare benefit that actually has nothing to do, this has to do with billing and coding tactics, that actually has nothing to do with the clinical care delivered to patients. Other concerns we might have are around sort of anti-competitive effects in a market and sort of self-preferencing of conglomerates that own many sort of related businesses, to sort of put it in the kind of business terms. But to make it more concrete, for example, if you go into Oregon Medical Clinic today, you might notice in the waiting room that there are fewer sort of magazines to like read as you're waiting for your physicians, but there are flyers to sell you insurance in there. And that's something that you might expect when the insurance company owns the physician practice, that they want to sell you their insurance plan. Setting aside that this might be sort of unsavory, we might ask questions about whether we want this in our physician practices, there's anti-competitive concerns here about whether United then can basically compete on unfair grounds with other insurers if they can basically advertise to them in a physician practice. The flip side example is true too. If you're an independent practice in a given local area where you have these insurance companies that also own physician practices, you might be concerned about ways in which the insurance company can squeeze the independent provider, or mind you, the independent pharmacy, in ways that makes business harder for them because they're an insurance company contracting with them and can preference their own subsidiary who is on the provider side. For example, one example of this might be the insurance company might go to the independent unaffiliated physician practice and say, as a condition of participation, as a condition of me contracting with you as a physician provider, you need to sell your practice to my subsidiary when you're ready to sell. So we see that sort of practice in a market. These again are sort of attempts, or on the pharmacy side, we might be concerned about ways in which the insurance company that also owns the pharmacy benefit manager and the pharmacy might steer business to their own pharmacy rather than an independent clinic, again raising concerns about essentially attempts to monopolize a given market, so anti-competitive concerns. And then the last, as I wrap here, circles back on really what Nick was talking about, which is that there's a real question about, as we see increasing sort of demoralization of the medical profession to sort of existential levels, whether corporatization, corporate control is the solution to this. There's a real question here. Again, there's an upside case for this, that corporate investment is going to allow clinicians to do what they want and just practice medicine. But you also hear that there's a more concerning version of this story, which is that oftentimes these investors might want, you have a bit of a Faustian bargain here. These investors might want some control over the medical practice in ways that might influence clinical care and might force this sort of clash between a physician's primary interest and desire and obligation to take care of their patients and a corporation's, in fact, fiduciary duty to maximize profits. So I think there's a real question as we see these corporate ownership of practices, whether we're forcing a clash, an irreconcilable clash between profit-seeking motives and the primary responsibilities of physicians in their interest and what they want to do, which is just to primarily put their patients first. Whole range of things that we could do about this from a policy perspective if we wanted to, one of which is at the state level, looking at state corporate practice of medicine bans, and I think that's a good segue to Representative Bowman. So thank you.
Good afternoon, everyone. My name is Ben Bowman. I'm a state representative from the Tigard and Beaverton area up in Washington County and the Oregon House Majority Leader. And I'm here to talk to you about the corporate practice of medicine doctrine. Has anyone here heard of CPOM before, Corporate Practice of Medicine Doctrine? A couple people. So the Corporate Practice of Medicine Doctrine has existed in this state for over 75 years. It exists in most states across the country, red states and blue states, and it's relatively uncontroversial. You will not hear from people who say we should get rid of the Corporate Practice of Medicine Doctrine. What it basically says is this: physicians or other advanced care providers have to be in charge of medical practices. They have to be in control of making the decisions of medical practices. That's what CPOM means. In Oregon, we have a 51% ownership requirement. So the docs or the nurse practitioners have to have at least 51% ownership stake in the clinics. That's the law. At the same time, as Hayden discussed, there's a rapid increase happening where corporations and private equity firms are gobbling up these medical practices. So if you're like me, you may be a little confused by that. You just told me that these practices have to be owned by providers, and at the same time, private equity and large corporations are purchasing up clinics. How can that be true? Well, the answer lies in a series of somewhat complicated workarounds and loopholes that have been designed by teams of corporate attorneys to avoid the Corporate Practice of Medicine Doctrine. So what essentially happens is they call this the MSO-friendly PC model, Management Service Organization Friendly PC model. What that basically means is that on paper, there is a physician owner. Now that physician doesn't have to live in the community, doesn't have to practice at the clinic, in fact, doesn't have to ever have set foot in the clinic, but on paper, they're the owner. Meanwhile, the corporation or the private equity firm has a wholly owned subsidiary that they call an MSO, a Management Service Organization, and that MSO then controls the decision-making authority through a contractual arrangement with the physician owner, where that physician owner basically delegates all decision-making authority over to that wholly owned subsidiary of the private equity firm. And in exchange, as you can imagine, that paper owner receives some compensation for that agreement. So why does that matter? Why should we care about that? Well, the outcomes of private equity ownership of physician practices is well studied, and here's what happens. Outcomes get worse for patients, costs go up, and physician independence declines. That's what happens when corporate takeovers happen. So we have a choice here in Oregon that we're going to have to make. Either we believe the Corporate Practice of Medicine Doctrine, which asserts that physicians need to be in charge of medical practices, either we believe that should be true, or we think it's an acceptable outcome for large corporations and private equity firms to circumvent that law in order to exert control over medical practices. For me, as a legislator, as someone who has an obligation to my constituents and to all Oregonians, I feel very strongly that the Corporate Practice of Medicine Doctrine should mean something in this state, and that physicians and advanced practice providers should be in charge. So you might be wondering, why would private equity want to get in the healthcare game so badly? What's actually driving this? Well, think about it. If you take over the control of a clinic, there are a series of levers that you are able to control. One of which is to deny Medicaid patients. Your reimbursement rate is a little bit lower for Medicaid patients. So if you're just, as Hayden mentioned, seeking profit, one thing you can do is say, we're not going to see low-income folks anymore because we lose a little money on that. We're not going to see it. We're just going to see private pay patients. You could say, I think we've got a few too many nurses. We're gonna get rid of some of the nurses. You could say, hey doc, you're spending about 20 or 30 minutes with patients. We want to cut that down to about 10 or 15 minutes per patient. You can change the types of providers that you're employing so that you're only employing the ones who cost you less money. All sorts of outcomes that really bring into stark relief something that Hayden said that I want to underscore for you. Corporations and private equity firms have a fiduciary duty to their shareholders to maximize profit, to make the most amount of money they can. It doesn't make them evil, it doesn't make them bad people, but that is their duty. That's their job. A physician and other provider, they have a very different duty. They have an ethical obligation to care for their patients. And when you have ceded control to a corporate owner, that fiduciary duty then overtakes the physician's duty to their patients. That is a big problem for us. That's a big problem, and you're gonna hear what happened in this community when that was circumvented and a corporate owner was allowed to take over and exert control. So what are we trying to do in Oregon? In the last legislative session, I introduced a bill, House Bill 4130, and the bill essentially closes those loopholes that I just mentioned and basically says no corporation can overtake control of a medical practice. A physician has to both own and control decisions that will impact patient care. That's what the legislation said. There's a bit more to it. We banned non-compete agreements. This is what large corporations or private equity firms will use to basically handcuff their physicians and say, you either work for us or you work for nobody. We banned what's called stock transfer restriction agreements. This is basically a complicated way that they design a legal arrangement that says, Doc, you're the owner of the clinic, but you can't sell it unless we let you. We decide when you can sell it, and we have to approve who you sell it to when you do sell it. So basically rendering ownership somewhat meaningless by controlling what ownership actually means. So we had several provisions in the bill that tried to reassert the corporate practice of medicine doctrine as the law of the land in Oregon. And it got off to a great start. The bill passed out of the House Healthcare Committee with a bipartisan vote. It passed off of the floor of the House with a broadly bipartisan vote. And then people realized that, holy cow, this thing might actually become law. And what we saw was a rapid increase in the number of paid lobbyists coming to fight the bill. And so there was a showdown in the Senate. Bill gets over to the Senate, and there was a very, let's call it an animated Senate Healthcare Committee meeting. And eventually the bill passes out of the Healthcare Committee. And to make a long story short, folks are saying, well, more people want to talk about this. We need to provide more opportunity for people to weigh in. We said, okay, we'll send it to the Rules Committee. And the Rules Committee holds another hearing, and it's several hours long. Everybody in the state of Oregon who wanted to weigh in and provide comment was provided that opportunity, and people weighed in and provided comment. It passes out of the Rules Committee, and it goes, next stop is the floor of the Senate, and if it passes the floor of the Senate, it then goes to the governor's desk for signature. All it's got to do is pass the floor of the Senate. We had Republican chief sponsor in the Senate. We knew we had the votes among the Senate Democrats, and 2 days before it was scheduled to come up for a vote, the session adjourned because it was a short session. We only had 32 days in session, so the bill never had the opportunity to come up for a vote. So in the ensuing several months, my Chief of Staff, Seth Dugan-Knight, is here. He has been hosting work groups where we've invited anyone with an interest in this bill to come weigh in and provide their input so we can adjust the bill and bring back a concept in 2025. Over 100 people have showed up to those work group meetings, and we're bringing back a concept that will look a little different than it did last session, but fundamentally will do the same thing, which is ensure physicians are in charge. And I'll leave you with the choice that former Governor John Kitzhaber offered to the Healthcare Committee when he came to testify. He said, we have a decision to make as a state. Either we believe that healthcare is a public good, or we believe it's an economic commodity that can be bought and sold on the stock exchange just like every other commodity. And I believe strongly that healthcare is a public good that every person should have access to in Oregon. So next up, you're going to hear from a legislator who has been working their tail off to preserve access to healthcare in Lane County, Representative Nancy Nathanson.
Thank you. I'm Nancy Nathanson, State Representative, District 13. In less than a year, the Eugene-Springfield community had experienced two major disruptions in access to care. The University District Hospital had closed on December 1st, and 32 doctors had left Oregon Medical Group. This past March, I saw a panicked note on Nextdoor, the social media app, someone who couldn't get care any longer from Oregon Medical Group and was asking help finding a doctor. There were a handful of replies, then more posts and dozens of replies. I could see that something with potentially dire consequences was developing rapidly, loss of access to primary and specialty care. I started making calls to professional organizations and public agencies, Lane County Medical Society, Oregon Medical Association, Lane County Health and Human Services, Public Health, Oregon Medical Board, Department of Justice, the Insurance Division. I alerted the governor's office. I talked with reporters. As soon as I did that, more people contacted my office, letting me know what was happening. Some of the serious problems that were happening in our community. People were self-rationing their prescriptions, reducing their dose or frequency to stretch medication as long as they could because they had no way to get a refill and didn't know when they'd get help. It was dangerous. Medications for lupus, diabetes, Parkinson's disease. Annual wellness checks for children had been canceled, and they missed their routine and required immunizations. At the same time, our community happened to be experiencing the beginning of a pertussis outbreak. The wait time for an appointment grew from 2 to 3 weeks to 2 to 3 months. It would take 2 weeks just to get a call back from another clinic about the possibility of maybe getting assigned a new doctor somewhere. Inexcusably, many patients had not even been notified by OMG. Some were longtime OMG patients, 10 years, 20 years or more. The reassignment process to a new doctor was confused, and many were told that there was no one else to assign them to and that they should look elsewhere, even when their physician associate or nurse practitioner was still there. Patients on Medicare were especially challenged, with many clinics not accepting Medicare patients. Written and verbal communication was faulty, with people believing they had lost all access to care at OMG. Whether that is really the case is still not clear, but people felt that and read that in the letter that they had, their words, been fired by their clinic. People were anxious, scared, worried, angry. One message, as jarring as it was to read, says a lot, and I quote, "My cat has better health care." Doctors, too, were under stress. Those who wanted to leave OMG wouldn't be able to continue practice here because of non-compete language in legacy contracts with OMG that Optum had inherited. The status of enforcement was unclear, but I talked with doctors who thought, and some who knew, that the non-compete was being or would be enforced. This was terribly stressful for patients, scary for families, and heartbreaking for the doctors trying to manage their own emotional and physical health, as well as that of their patients. To address the unfolding crisis, I talked with my legislative colleagues here and with Congresswoman Hoyle. I met with Optum in Eugene on April 9th. They told me about their vision for a better way to provide health care through a comprehensive team approach to wraparound services. We, the local delegation, sent a letter to Optum on April 17th requesting a response in 10 days. Meanwhile, on April 23rd, the Federal Trade Commission announced a ban on non-compete contracts or agreements. Welcome news, but you needed to read the details and understand the process. It would take 4 months before it might even become in effect after publication in the Federal Register. I wondered whether ultimately it would become rule anyway because of legal challenges and immediate strong pushback. Don't get me wrong, I was very pleased about the FTC action. We just couldn't count on it, and it wasn't going to help our immediate situation. Optum replied then on April 27th, meeting the 10-day target, and explained they would not enforce non-compete language. It was a 2-page letter with lots of detail. Senator Przanski joined me for another in-person meeting with Optum where we hashed out the fine points. Shortly afterwards, Optum affirmed that they will not enforce non-compete language in Oregon and that they will continue processing prescription refill requests. To summarize the local situation, there was absolutely a disruption in continuity of care. Thousands couldn't get appointments, couldn't find new doctors, couldn't get prescriptions refilled, vaccinations were missed, people were worried and anxious. Serious consequences seemed to result from faulty business practices or administrative shortcomings. Notifications didn't happen as required. Meanwhile, where possible, Optum is continuing to reassign patients. There was a noticeable and costly negative impact on the rest of our system. People reached out in desperation for help, advice, and treatment, reached out to retired doctors and specialists who don't normally address primary care needs. And Lane County Public Health, both hospitals in Springfield, coordinated care organizations, and the Medical Society all confirmed that there was a noticeable impact, adverse impact, on already stressed emergency care network, like calling 911 for medication advice and people showing up at hospital emergency departments. Some good news, Since January 1st, Optum has hired 18 primary care and specialist advanced practice clinicians. That means doctors, physician associates, and nurse practitioners. 5 new providers will be coming on board this summer and early fall. And that OMG clinic that closed in South Eugene, Practice, a 3-state, quote, how they describe themselves, a family of medical groups, is opening in that space on August 1st. Few observations to leave you with real quickly at the 30,000-foot level. Consumers were paying monthly premiums for health insurance and not receiving care. Not being able to get an appointment, that's bad for the patient, but for the shareholder who isn't paying a provider, that's fine. Continuity of care has been disrupted. The weight of patient abandonment falls squarely and legally on the doctor's shoulders. But is the doctor always ultimately responsible when limited by quotas and directives, a time clock, and a coding system? What is the corporate responsibility when patients receive delayed or substandard or no care? Oregon requires doctors to be licensed, and nurses, teachers, truck drivers, plumbers, barbers, but not the companies that control our health care. What is our legal relationship with them, and what is their obligation to us? There's a dire shortage of doctors nationally. It's going to get worse, and when enforced, non-compete agreements artificially further suppress the supply of health care. And finally, decisions based on corporate profits are costly, transferring cost and risk to patients, to other providers, and to the public sector. That means transferring costs to taxpayers. The impact and cost of this disruption was felt by 911 and hospitals and other providers. Thank you.
There was so much content from the 3 speakers that I hope you didn't miss the strident defense of 2-year-old Field & Streams in the doctor's waiting room. Thank you, Representative Bowman. Thank you. We'll begin our Q&A in just a moment, but first I'd like to thank the business and in-kind sponsors whose support helps make City Club possible. Network Charter School, Hirschner Hunter LLC, Evans Elder Brown and Subert, Hudson Dental, and Luvas Cobb. And also thanks to our in-kind sponsors, KRVM 91.9 Radio, Alpha IT, Dot Dots and Photography, and Kids Sports. Also, special thanks to our award-winning public radio station, KLCC FM 89.7, for airing City Club programs on Monday evenings at 7 p.m. For those listening at home right now, your household is one of several thousand tuning into City Club on KLCC. We love that you're here. You can also find recent City Club programs archived on KLCC, as well as on our YouTube channel and podcast. We'll take a brief break and come back for questions for the panel in about 5 minutes. Thank you. to City Club of Eugene, July 19th program. Question and answer period. The first question will be asked by Dr. Jones.
Yes. I can speak loudly, but I don't.
No, I think it's on.
Oh, okay, there we go. So for those of us that want to get engaged, whether it's patients, nurses, doctors that want to share their experiences in healthcare, whether it's in support of this bill or I understand that it's going to be changing from last year, if they have concerns over any unintended consequences, what are some of the best ways to get involved?
This is Ben Bowman. Great question. The easiest way is to email my office, rep.benbowman@oregonlegislature.gov. And particularly if you have experienced what's happened here in Eugene, either as a provider or as a patient, if you received a letter in the mail or a phone call and you want to provide your story, that's incredibly impactful down in Salem for legislators to put a story to the policy issue. So please don't hesitate to reach out. Representative Nathanson, anything to add?
I'd like to make people aware of the New York Times investigation on what's going on with the consolidation of healthcare. I've been in contact with a New York Times reporter, and they are inviting people to fill out a questionnaire. If New York Times says, the Times wants to understand what it has meant for Optum's patients and medical professionals. We'd especially like to know about any changes that occur when Optum buys or contracts with medical practice. So if you write to my office, my legislative office, Rep. Nancy Nathanson, we will send you a link if you would like to fill out that questionnaire, because then this will help the New York Times look into the situation as well.
Okay. First question. Next question.
Hi, Kelly Johnson, City Club member. Thank you all for being here and addressing this important issue. It all sounds pretty dire, and I'm just wondering if you guys have any kind of bright spots, innovative models that are working, or other states that are kind of rectifying the system that we could look to for hope.
I'm going to go ahead and start by answering this one. I'm a relatively young physician. I came here in 2020 straight out of my residency training. There's a model of care called direct care, and whether it's direct primary care or direct specialty care, over the last 30 years, it went from the first practice in 1997 to over 3,000 practices across the country, often with multiple doctors. And what they do is they try and figure out what healthcare actually costs. So they can get blood work for patients for $6, $5. They can get prescriptions directly from manufacturers for 2 or 3 cents a pill. They bill on a membership model, a set it and forget it type model that allows them to go back to old-fashioned medicine, where patients set up a monthly fee and then they just take care of them, whether that's at a grocery store, on the phone, texting, emailing, that sort of stuff. And these models are doing incredibly well, and they're actually having a difficult time right now as a movement in getting enough doctors, right? Because again, like I mentioned before, doctors are spending over a decade of their life trying to train, and they get a lot of medical debt in addition to undergraduate debt. God forbid they want to start a family. They want to buy their first home or their first new car, and so they can't compete with these sign-on packages that corporations are providing. But at least in the primary care space, that is what really motivates me and energizes me, and why I opened up my own practice. And you may be surprised to find that there's over a dozen of these types of practices here in Eugene already. But most of those physicians filled up with patients, and I have a vision that, you know, to care for more patients and to increase access, we can hire support staff and try and model it in a way where there's actual physician leadership. But that's something that I get hopeful about.
Anyone else? Go ahead.
Yeah, sure. So, you know, Nick mentioned one model of care that exists. I think it's important to recognize there are others other than the sort of corporate model, which is, you know, growing and predominant. You know, I mentioned the sort of nearly 80% statistic. But there still are physician-led practices. There are many nonprofit community health centers, rural health centers, federally qualified health centers. Their health and hospital districts actually exist here in Oregon, where there's local control and ownership of skilled nursing homes, of primary care clinics. There's health departments that provide some level of medical care as well. And I think the important thing to just recognize is that we have a decision collectively as a community, as a state, as a nation to organize and design the type of system that we want. I'm always citing the statistics, but already, even right now, we have a healthcare system that's almost 70% taxpayer financed. So the question is not about just like this question of like, whether the government's involved or whether it's not. We're deciding, policymakers are deciding how to design our system, and we can structure it differently if we want to. If we don't want, a system where insurance companies are owning physician practices, whole range of tools. Ben talked about one that he's pursuing to try to ensure that, for-profit medical practices are owned by physicians. There are a whole bunch of policy levers to pull here if we want something different, if we're concerned about who's in control and what the sort of ownership structure looks like right now in our healthcare system.
Just real briefly, it's a great question because I feel like it is bleak sometimes too. But here's what I think about. Oregon has been a national leader on healthcare reform for decades. The Oregon Health Plan was a national model in bending the cost curve and improving patient outcomes. We did it again with coordinated care organizations, CCOs. So this is in our DNA as a state. We just got to step up and get it done and build the future.
Oregon also passed really aggressive legislation trying to rein in pharmacy benefit managers, which are part of this vertical integration issue that we're dealing with. So yeah, Oregon has the know-how. We just need the gumption and some good ideas to do it. There's something else I'd like to add, food for thought. Not only is the business of healthcare changing, but the delivery of healthcare is changing. And as I think about it, are we the victims of these changes, or can we be the beneficiaries of the change? There are some things that make people really nervous, really scared, but they can also be helpful. For example, thinking about robotics and telemedicine and remote diagnostics, that can enable increased in-home care. Maybe that's a good thing, not a bad thing. So there are many aspects of the delivery of healthcare also that I want us to think about going forward.
Sir?
Hi, Bill Kleppinger. I've had this shirt for probably 12 years, and I haven't seen much progress toward getting universal health care for everyone.
Can we mention what the shirt says for the people on the radio? Healthcare is a human right.
Yeah.
Go ahead.
The question that I have is, once we've got corporate ownership, we've heard about all the bad things about it and we've experienced it. But my underlying question is, why sell out to a corporation? What's behind, and maybe somebody addressed it, some kind of buyout package. Is it that lucrative that a private practice wants to get a bunch of money instead of continuing? Does that make sense?
This is Dr. Nicholas Jones. So first I want to say that, I didn't have any knowledge about the specific amounts or anything like that. But what I can say is that it is incredibly challenging to run a profitable medical practice. You have so many other stakeholders involved, and you have to pay for your IT department, your HR department, your call center, your front desk staff, your nurse triage, all of these people that help support caring for patients indirectly. But when you're paid in a fee-for-service model where you only make money per visit, the math adds up pretty quickly, and you have to see a lot of patients. And over the last decade or so, they've been moving towards a value-based model, which actually incentivizes people to be sicker and have these more complex diagnoses. But the way to track all of that data costs multi-million-dollar medical record systems. I think something to the tune of $40,000 to $50,000 per year per doctor. And so when an independent practice is struggling to keep pace, it's more of a financial stability type move and making sure that your clinic doors don't shut down, especially when we have the unprecedented COVID pandemic. And if you're living and dying by appointments and everybody's worried about getting sick and they don't want to come in, you're hemorrhaging money because all of your overhead, all of your payroll, all of that stuff is still there. And I think it's really unfortunate that what we have is this huge healthcare system where it takes resources to make money. The more resources you have, the more profitable you can be. But what about the people that want to start a practice from scratch? What about the people that want to practice in a way that makes sense for them, that are okay making a little bit less money? They get pushed out. And so, at least in my experience in primary care throughout the pandemic, I see it as less lucrative, as more of a necessity. And I think that we have to make changes where healthcare is more affordable, accessible, and we're not having insurance companies skim off of the top of every single transaction in healthcare, because that artificially inflates the price, the cost, making it more challenging for physicians to stay in practice, and can hopefully eventually lead to healthcare for all. And there is a movement of Healthcare for All Oregon, but that's not for today's discussion. That could take up the entire rest of the time.
So what I think is important to note, so there's some independent clinics that we've been working with on this legislation for a couple years, and some of them are in the practice of forwarding to our office every time they get a solicitation to buy or invest in the clinics, and it is happening dozens of times every month. So there's tons of people in the PE world and the corporate world who are engaged in this. What they promise is nothing's going to change. Nothing's going to change. We're not going to impact patient care at all. That's not what we do. My understanding is that's what happened in this area. Nothing's going to change. It's all going to stay the same. And then a year goes by or 2 years go by, and all of a sudden they're exercising the control that they've taken over in the buy-up, and things start to look a lot different. But I think it is important to know, you asked, is it really that lucrative? Yes. Yes, it is millions of dollars that is being offered, oftentimes above what the actual value of the clinic is, because they believe they can come in and turn those levers that I mentioned to make it more profitable on paper, so they can essentially flip the clinic like you'd flip a house.
That raises a question. Have practices then been resold?
Yes, quite a bit. I mean, I think Oregon Medical Group is actually somewhat of an example of this. But if you zoom out, and sorry, this is Hayden Rookley. Depending on the corporate investor, on the corporate owner, you see varying degrees of sort of resell. When we talk about private equity in particular, I mean, this is a very well-known and sort of acknowledged aspect of the business model. The point is not to hold on to the investment for a long period of time. The investors, the LPs as they're referred to, put up the money, want that return in a matter of 3 to 7 years. So you often will see a physician practice sold many times from one, basically across the life cycle, as they call it, of the investment, from early stage to sort of later stage private equity, and then oftentimes ultimately sold to one of these larger conglomerates. So there's a quote, I forget who had it, of a private equity investor who recently said, so all roads lead to Optum. So you sell, this company gets flipped by these early stage investors, and oftentimes you see these insurance conglomerates in joint ventures with private equity companies. So Humana, for example, Elevance actually, which was formerly Anthem, has just announced a venture where they are basically going to try to really quickly acquire physician practices. And the whole idea here is to amass scale quickly and then flip it. The sort of investment is in aggregating size. So you see rapid investment, sometimes in these joint ventures, to consolidate a given market, and then that's lucrative to one of these larger conglomerates like an insurance company to sell the whole thing to. So absolutely, to answer your question more succinctly, yeah, you see resell quite a bit actually.
Thank you. Sharon?
Sharon Reed, City Club member. I'm curious, are individual doctors or other health professionals given a quantifiable revenue goal by the insurance operator or owner? I mean, are they expected to meet like certain billable hours or billable appointments and a certain threshold, or they are moved out? So it's, are they facing those pressures?
Really quickly, again, those pressures that I alluded to before, there are going to be some mix of the patients per day that you're seeing multiplied by the buttons that you're clicking to justify their medical complexity. And then there are these other innovative models that are trying to look at the value of the doctor, and so they're seeing, what percentage of your blood pressures are under control, what percentage of your diabetes is under control, and giving out bonuses. The problem that I see is that the company will claw back these things and say, okay, we're going to pay you 10, 15% less, but you have the opportunity to make 10 to 15% more than you were before if you meet all of these metrics. And sometimes it's things that are out of our control. Maybe patient satisfaction surveys that say, how quickly do you get a response? Well, if that doctor has 3,000 patients, and the national average is 2,500, whether you're fresh out of school or been in practice 30 years, you don't have any control over those sorts of things. And you lose the art of medicine. When a patient hasn't had their blood sugar in control for 20 years, and they're half a point above that metric, but it's the lowest it's ever been, that's a success for that patient. But that penalizes the doctor. And so there's all of these mental games that doctors and clinicians have to play, and they know what impact it has on their revenue. And so I wouldn't say that they're coming in heavy-handed and saying, you must do this, you must do that. It's not that obvious, but when you get your paycheck, when you see what are you producing, it's very obvious what's profitable and what's not. And so those type of mental gymnastics weren't something I wanted to do for the rest of my career.
Anyone else?
I would just say real quickly, I've heard stories both quite explicit and more implicit, as Nick said. So it can be anything from, you hear about this in the hospital setting too. Physicians might be told, you must discharge a patient by this time because, large corporate hospitals have the incentive to get the get the patient out as quickly as possible because they're paid a lump sum payment to see the patient. Or maybe to triage the patient in the emergency room setting, the physicians might be told you need to do that quickly to see the next one. Or as Nick was saying, control of the schedule is really powerful when a corporate owner controls the schedule. There's actually a dispute in California right now over a private equity staffing company in the emergency room setting as a violation of their corporate practice of medicine ban, where the controlling the schedule of these physicians is a way to essentially exercise control over them. And if they're not seeing enough patients, if they're not doing enough billing, they can actually remove them from the schedule, which is basically a de facto way of getting rid of them. So the answer is absolutely yes. These practices are quite rampant. And I think part of the talking about this is just to illustrate, so we all sort of know sort of what's occurring here, because I think really it's often just physicians, honestly, who understand kind of how this is happening, and they're of course subject to these constraints.
Sir?
I'm Daniel Pope.
Excuse me just a second.
I'm going to add just a couple of small points because I've talked to so many patients as well as doctors here in the area in the last few months. One of my communications was from someone who said that their provider, an advanced practice clinician, told them that they received additional pay every time they prescribed medication. Doctors that I talked to told me what their patient panel, their number of patients was like a couple years ago, and then last year, and then what they were being asked to increase to. It went from 1,000 or 1,500 to 2,000 with a goal of moving up to 2,500 for a patient panel. And so it's not so much that there were revenue goals, but there were expectations of how many people you would see in a day. So rather than increased revenue, it was more about decreased time with patients.
I'm Daniel Pope, not a City Club member yet.
We can change that.
As a senior, so much of this seems to revolve around questions related to Medicare and in particular Medicare Advantage. We're among those, my wife and I, who were booted out of OMG and found direct primary care, but it saddens me. We're happy with the physician we have. We're happy with the arrangement which we can handle financially. But it saddens me that one of the great reforms of the mid-20th century, Medicare, is not functioning for so many people, or is functioning in a way that pushes down the quality and availability of health care. Can we survive with Medicare Advantage gobbling up the majority of senior patients?
I think Hayden Rookley is probably a good.
Yeah, this is Hayden Rookley again. Yeah, I mean, I think I alluded to this earlier. The Medicare program looks entirely different than it did really from a decade ago. The government has made the decision, sometimes explicitly, sometimes not so much, as sort of the progression of the program, to really privatize it. Again, a decade ago it looked much different, and that has a bunch of cascading effects. So yes, absolutely. A lot of this is federal reform that needs to happen. We could decide to reinvest in our Medicare program, cover vision and dental, have out-of-pocket costs for traditional Medicare because of the subsidization of the private version of Medicare. Again, we pay about 20 to 30% more for the private version. Some patients are offered, cheaper premiums, so they flock to that. But then they realize on the back end that all sorts of games might be played. Most concerningly, actually, just denials of care, so narrower networks in Medicare Advantage benefits. So again, I go back to the same thing I said earlier. This can be changed, and Nick alluded to this too. Oregon could actually change this itself as well. If it wanted to go most ambitiously towards a version where we stood up our own system and got rid of all our insurance companies and set up our own universal healthcare system here in Oregon. And there have long been advocates in the state who want to push towards that direction. So again, the possibility is absolutely there, is the point I'm going to just underline again.
There was a mention made that the bill 4130 is going to be changed before introduction. What changes are going to be made?
It's a good question. This is Ben Bowman. We haven't made any final decisions yet about what's going to be in, what's going to be out. You can imagine the chorus of lobbyists and other interests who are asking for certain things to be changed. Some of them, I believe, can be done without impacting the core of the bill. And there are lots of different ownership models, some of which are technically different than what the bill prescribes, that also preserve physician independence. It gets very complex very quickly. We are vetting, actually this weekend, my chief of staff and I are going to sit down and vet all they call them red line changes, where people will edit the bill and then present their edits to us to evaluate what goes in, what comes out. There's also potential that we'll expand the bill beyond what was covered last time. There were exemptions built into the last piece of legislation. For example, telemedicine was exempted from the requirements, and we're evaluating whether or not that should be true, whether or not these exemptions should be in the bill. There's provisions like the non-compete agreements. Who should the non-compete agreements apply to? If all the owners of a clinic are physicians with an equal share, should they be able to enforce non-competes among their colleagues? There's little provisions like that, but the core of the bill about ensuring physicians are in control will be locked in and not moving.
The non-compete provisions applies only to doctors, or does it apply to any business that wants to have a non-compete clause?
Hayden, do you remember the details of the non-compete provision?
Yeah, this is Hayden Rookley. So I don't think within the scope of the bill it addressed non-clinicians. So we're talking about particularly physicians, advanced practice providers, other industries. Rep. Nathan talked about the FTC rule that may go into effect, we'll see here, applies across the American economy. But I think for the purposes of this bill, the focus was on physicians and other advanced practice providers. Yeah.
Anybody else want to address that?
I'm going to take the opportunity before we close. First of all, Oregon does already have non-compete law. It just didn't go far enough. It's limited under a certain, it has to do with what the salary level is, for example, what your own personal situation is. So our own non-compete law isn't useful the way it is right now to address the situation. I also wanted to make sure that if no one has an additional question about vertical integration, I would love to share with you a chart that I'm looking at. There were Humana, Aetna, some of those names that were mentioned today. I spent a couple of years working on passing some regulation for pharmacy benefit managers. And I'm looking at a chart here right now demonstrating what insurers own: the pharmacy benefit manager, the pharmacies, and the provider services and clinics. It's throughout the system, and it's alarming.
One last question and quick answer. What other towns in Oregon have had the same problem as Eugene?
This is Ben Bowman. It looks different in every community. The Corvallis Clinic up in Corvallis is a very prominent example of, I think they're a couple years behind what happened with the Oregon Medical Group. The transition just happened. But there's PE firms and corporations who own clinics in almost every community in this state. Ones that you've never heard of. There's very little transparency in this, so most patients don't actually know that their clinic is owned by a PE owner or a big corporation. But this is far more widespread than most folks believe.
Yeah, Rep Bowman and I were actually just out in Bend last night and speaking with independent anesthesiologists out there, and there was a corporate owner that came in a few years ago, and apparently across a number of different specialists, drove a number of their top, I think, orthopedic surgeons, other specialists out there, basically out of town. So there are definitely other areas in Oregon where some of this sort of corporate consolidation has occurred, and not necessarily to the benefit of the physicians or the community.
Thank you. Thank you. That's all the time we have for today. Please join us in thanking our panelists. This has been our July 19th conversation at the City Club of Eugene. Next Friday, July 26th, we'll be back here with another program dealing with a specific area of healthcare. For the final program before our August recess and community affairs, this program will concentrate on Parkinson's disease. Thank you for joining us. Have a wonderful weekend.